Again, first of all, I want to thank Dr. Jyotidev and the team to invite me to speak on this topic. I think my first two speakers have already set the stage on the basics of CGM. I speak how you integrate CGM into a pump so that you get an automated insulin delivery system. So this is my disclosure. But again, this is not a Medtronic sponsored symposium. So now, we all know CGM. It gives a lot of insights, but then if you don't take action, there's no value. So that's why. So even with CGM, a lot of people still globally do not achieve good glycemic, especially type 1. So the challenge is still people have A1C below 7. So this is the current statement. Now, what are the options we have? Either you intensify, especially for a type 1, you intensify in the AID if you are on an insulin pen or a syringe, or you use a insulin pen with a CGM. And the data shows if you are on MDI or only MDI or CGM alone, or a mixture of CGM and MDI and AID, the glycemic control goes significantly up. As I told, standalone CGM provides alerts but no actions. It's the role of the physician or the device you're using so that you get better control. If you don't take any action, no value at all. Now, what if you could have a pump therapy, insulin pump that can take action based on the sensor readings? So, we're talking about automated insulin delivery system. So you have a pump, you have a continuous glucose monitoring system, and then you have an algorithm. Okay, so the data from the sensor goes to the device, which has a AI/ML-driven algorithm, and that algorithm says the pump to push this much basal or this much bolus, depending on the glycemic level of patient during that time. And also it takes into a lot of other parameters. That's we call automated insulin delivery system. You have a pump, you have a sensor, then you have an algorithm. And the algorithm can be inside the pump system, the pump machine, or sometimes some devices they have the algorithm in the mobile device. The mobile also can have a algorithm. Or if you do it yourself, DIY AIDs, in that mostly the algorithm will be in the mobile. But in case of this pump, the algorithm is inside the pump device. So this is the one only available in India. Although globally there are 5 or 6 automated insulin delivery devices, India has only Medtronic, that is 70 system. So it integrates insulin sensor and then it gives you action. So this AID, automated insulin delivery system, works on this algorithm. The algorithm is called PID, proportional integral derivative with insulin feedback with predictive controls. It is a very well-known algorithm used in the heating system. The AC cooling system works on this algorithm, PID. It takes into account the sensor glucose value, how far it is, how far away from the target, how rapidly it is changing, and what is the amount of insulin already active in your body. It takes into all this into account and then the algorithm. It's a very old algorithm, PID, maybe at least 5 decades or 10 decades. Now, as I said, depending on the sensor glucose values, automatically it pushes basal insulin. And if needed, it will also give you auto corrections. If the sugar goes beyond 120 at maximal basal secretion, automatically the pump will give you microboluses so that you do not land at very high dose. And the algorithm also has these safety modules: safe correction bolus, meal detection, and safe meal bolus. So when you say what is safe correction, for example, if the sugars are high, what you do is automatically the system has, before it gives auto correction, it automatically within the system it checks if I give this much dose, will the patient land up in post correction hypoglycemia next to us? If it says yes, again it will rectify the dose and it is reduced by 25%. And again run that simulation. And it will run the simulation till the prediction says the patient will not land up in hypoglycemia, then it will give it. So this is safe auto correction. And then it also has a meal detection module. For example, you forget to give a meal bolus. Depending on the glucose rise after meal, it will automatically give a higher auto correction. Because if it came to know the algorithm that you have not given the bolus dose. Because it is not fully automated yet. It is still, I will say, partially, because the person who is using still has to bolus manually the meal bolus. That's the only thing the patient has to do. But if it forgets, then the system automatically does it. And then for every meal bolus, as I said, the person has to calculate little bit of carb counting, little bit. But then once he enters the carb, again the system will run a simulation that if the recommendation is for example 10 units, it will run the simulation that in the next 4 hours, because postprandial hypoglycemia is the most common hypoglycemia we see in type 1 diabetes. So this is a safety module just to avoid postprandial hypoglycemia. We have these, so this is model predictive control, part of the algorithm. And so this algorithm adjusts all the parameters every night on these values: sensor data, comp data, meal announcement data, and the input it takes from the last 2 to 14 days. And it also changes sensitivity factor, Umax, same basal, and glucose prediction models. So automatically it calculates every midnight. So then what's the role of a physician like you and me? So the algorithm will do auto basal, auto corrections, and ISF. As a clinician, our role is to set what target you want for your user, 100, 110 or 120. What should be the active insulin time and what should be the carb ratio. This is the only thing you have as a physician. Now the next generation which is coming, in maybe next 6 months or 1 year, the person automatically will also give the bolus. So you don't need to bolus for the meals. Automatically it will bolus. Now, as I showed, a lot of data has shown that if you use just MDI and ICJ, which is very, very famous or standard of care in Europe earlier, now versus the AID system, you can see from baseline to study, see the timing range difference, and from here you can see the timing range difference. When you integrate the delivery with the sensor. This is the same study in terms of A1C, you can see from 0 to 12 months, you can see the A1C sustained with the AID as compared to Libre 1 and MBA. And here, both the groups change to AID. And this was a very, very famous paper from Steno Diabetes, where they looked at MDI only, sensor unintegrated pump, means sensor and pump are not talking to each other. Sensor integrated pump, they are talking to each other, but action is not there. And you have an AID. And you can see the timing range. This is a real world observation data from Steno Diabetes. 54% MDI, sensor uninterrupted or unintegrated, 54.9, SFP 62.9, and an AID 72.1. Real world data. So definitely AID has significant advantage. And if you see the PPR, hypoglycemia, again AID will give you the best or the least hypoglycemia. So now on this system, now we have, I think, close to, now there are 210 publications, and for across the data, across the globe we have 210 publications on real world, and I think Dr. Pillai has already shown that. To review the therapy goals, if goals are not met, you do the changes and then get reviewed. So this is the dashboard. You look at the theory, you see the 24 hours overview. You also get this dashboard for your patients. Timing range, what is the insulin per day total, what is the basal total bolus and auto corrections, what is the average glucose, EMI, how many hypoglycemic episodes, hyperglycemic device usage. You get everything in one single shot, so that you don't need to see much more if you don't have time. And this is already here shown that this is the target when you're looking at a glycemic report, AGA report. And if you don't get that, then you take the necessary things. So ideally you need this. Ideally as a physician, I think I want to see this in every type 1 or type 2 person. And then all this data can come out of this AID report. It tells you how much sensor usage, what is the manual usage, how much sensor they have used, what is the GMI, a CV, average glucose, how much total daily dose is taking, average basal, average, everything you get in that one page. So if you don't have time, the full report is 22 pages. Normally, if you have an educator, she or he can see that report, analyze it, and give it to you. If you don't have a team, then this one page is at least a window enough to tell you what's happening. This data I have already shown you that from MDI to go to AID, you have significant improvement in time. So to summarize, now this is the latest, I think Dr. Rakesh knows, from our own Dr. Bansi Sabu. This came in the diabetes technical therapeutics. Call to action that the standard of care for any type 1 human adults should be AID, and for any reason, if you are not able to offer them, you should document it, whether it's for clinical reason or economic reason or for whatever, because you are not giving him the standard of care. So this is the call to action which is recently published in PPT. Dr. Bansi Sabu was the first author in that. Thank you. And this boy was, I don't know if you are at ADA, this boy was there at ADA to share about his experience on AID and his mom, his mother, how it changed his life and his family. Thank you.
Thank you, sir, for that wonderful talk. And before we allow the audience to ask questions, I have a CGM to put here and ask my doubt.